Thank you for joining us. Today our webinar topic is going to be on the roadmap to creating nationally peer-protected information, communication, and activities. My name is James Hayes. I'm the Education Services Project Manager for NCHA. This educational activity is jointly sponsored by Access Medical Education and NCHA. Access Medical Education designates this continuing nursing education activity for 0.75 contact hours. And you do need to be present live to receive those credits. Our faculty today is Shelby Lassiter, PSO Director, Clinical Performance Improvement for the NCHA Foundation. And Shelby, I will pass things over to you.
Thank you, James, and thank you everyone for being with us today. I'm going to introduce Peggy, but before I do, I want to take a brief moment to say thank you to all of our PSO members for working so hard and so diligently through this COVID-19 situation. We are, having been in the hospital for most of my career as a nurse, I know well that hospitals do a tremendous amount of preparation all the time for these kinds of things. And then when these surges hit, they're really stressed in providing staff and all of the supplies and the care that patients need. And you guys are just phenomenal. So I want to give you a shout out and say thank you from the bottom of my heart for all that you do and are doing. I know it's hard work, a lot of stress, and we are behind you to support you in every way possible. So please reach out if there is anything, and I don't care how minor you think it might be. If you need something, you reach out to me, and we, being here within the NCHA as our parent organization, can help mobilize resources or get you pointed in the right direction to support you. So don't hesitate to do that. So with that, we'll proceed with today's webinar. The content is wonderful. And I want to introduce Peggy Benzer. If you've not heard Peggy speak before, you have missed a treat, but you're in luck today. Peggy serves as the Executive Director of the Alliance for Quality Improvement and Patient Safety, or AQIPS, that many of you hear me refer to periodically. This is the nation's leading professional association for PSOs and our healthcare provider members. And in fact, part of your PSO membership fee goes to pay for membership in the AQIPS organization. And thereby, Peggy and her staff and team are available to us for consultation and guidance. So we are very thankful for that. Peggy is an attorney, and she spearheaded the crafting and passage of the Patient Safety and Quality Improvement Act of 2005 while serving as Senior Health Counsel for the U.S. Senate Health Education, Labor, and Pensions, or HELP Committee. As a partner in several law firms, she assisted hospitals and specialty physician associations, health systems, and management organizations become PSOs. She helped us, and provided health systems, pharmacy chains, and other providers with legal guidance to improve the quality of patient care and implement the PSQIA's protections. And we are so thankful and humbled that Peggy is part of AQIPS and is available to us to consult with. She is definitely an expert in this area. So with that, I will turn it over to Peggy.
Thank you so much, Shelby. Thank you for the wonderful introduction. I am definitely humbled and really need to live up to all of your statements. I'd also like to echo you in thanking all of our healthcare providers and frontline providers and all that they're doing in this pandemic, and also echoing your sentiments that if there's anything that the PSO community can do and come together with you, that we'd love to hear about it and love to know. And I'm hoping that PSOs can institute programs like the Quality Center has helped, peer support programs and other programs that can really help folks get through this time. So today we are going to talk about our second module in the learning series about the national peer protections. If you remember, in the first module, we really talked about what the national peer protections are and what a PSO is. Today we're going to get a little bit farther in the weeds and talk about how we can use the national protections to improve the quality of healthcare delivery. Also, how does the information and conversations become protected, and what exactly is protected? So we're going to try and tackle some of these questions today. And then our third installment, which will be next time, our Module 3, will be about the patient safety evaluation system, which is the process that we use within our health system or hospital or provider to move and flow this information to get to those who need it. So, but today we're going to talk about the pathways. How do we make information become privileged? Next slide, please. So let's talk about some key terms before we get started. We're trying really hard not to expect you to become legal champions of the law. We want to try and use as many clinical terms as we can, because this really is a clinical improvement law. But there are some terms that we all need to understand in order to understand how the national peer privilege works. So the first one is under the law, who is a healthcare provider? And a healthcare provider is a very broad definition. It includes all of our healthcare professionals, as well as our entities, all of our licensed entities. So that could be a hospital, a health system, nurse, doctor, chiropractor, anyone who has a license to provide healthcare services. Also, there is an extension to this definition, and that's anyone otherwise authorized under state law to provide health services. So that could include our ancillary providers, it could include home health, it could include assisted living, where care is given but not by a healthcare professional per se. So the definition is very broad, and all of our healthcare providers can work together, and you all have peer protections. So we can provide protections as a team. So we can have team huddles, for example, in an emergency room when something happens and we need to get together and talk about it. We can increase our confidential communications all together and not have to wait for a peer review committee meeting or an M&M or another type of protected conversation. Our patient safety activities, we're going to talk about it further today in our conversations. And those are very broad, again, defined very broadly, efforts to improve patient safety and healthcare delivery. So again, it's not just about event reporting and investigation and root cause analysis. It can be all of our quality improvement types of activities. The privilege. So we talked last time that we have a privilege and our providers have a confidentiality protection. But what exactly is a privilege? What does it mean? Well, a privilege by definition is a legal advantage, which is what is privileged is insulated from use against a healthcare professional in litigation. So all of the information that we collect and develop as our national peer protected information can never be used against you in any type of litigation. So that includes litigation, discovery, and evidence in any kind of civil proceeding. It also includes criminal proceedings, and we have sometimes seen criminal negligence cases against our providers, and so we can raise a privilege in those as well. It includes administrative proceedings, and it also includes proceedings from our medical boards. So very, very broad privilege so that we can use information that maybe we wouldn't otherwise collect if we didn't have protections. So we also have our term, patient safety work product. That is our protected information. That's the information that is privileged and confidential. Patient safety work product is defined very, very broadly. It's any memorandums, reports, any conversations, oral conversations, any documented conversations, any committee meetings are protected as patient safety work product. And patient safety work product also, it runs with the work product. So it can't be waived, and it's not owned by any particular provider. So a hospital, for example, cannot waive the privilege and use it against one of their healthcare professionals or vice versa. The work product runs with the data, so it never can be waived. And then patient safety evaluation system, that's going to be the focus of our next module, and that's really the system, our policies and procedures, and the processes that we follow in collecting and creating this protected patient safety work product, again, our protected information. So those are some of the key terms that we'll be using, and now we know the broad definition. Next slide, please. So what is privilege? What can't be used against us? So under the Act, the patient safety activities, and those are all efforts to improve patient safety and healthcare delivery, can be privileged, provided that we follow the pathways and processes that we're going to talk about today. So this includes every effort that we use to improve healthcare delivery. So again, it goes beyond quality improvement, our confidential event or incident reporting and investigations. It includes our process improvement, so we can do safety reviews. It includes clinical improvement, so we can audit our clinical folks. Our medical director can audit the performance of, for example, their service line professionals. And so we open up some new and interesting, innovative programs that we haven't been able to do before. Care optimization, our confidential peer support programs, such as the peer support program that the Quality Center developed with UNC. Awesome program. Systems improvement, since most patient harm occurs because of systems failures, we can really confidentially root out systems problems and systems analysis, and also ensure that our systems, such as our EHRs, are designed for safety and can prevent future harm, but also do not produce harm in and of themselves. So we have new systems, and so with new systems, there's always a new opportunity for harm. And then quality assurance programs. We have a number of secret shopper programs that are developing, where, for example, one health system developed a secret shopper program for hand washing, where they gave prizes to nurses and others who would watch and report whether people were washing their hands or not. And so this system improved hand washing so that hands were being washed 99% of the time, and it was a fun program. We're also seeing a lot of simulation now, simulation programs in training, and those we also can protect. So we're seeing a lot of activities, all that are driven to improve patient care and the delivery of patient care. So all of these efforts and any other efforts that you can think of can be protected. Next slide, please. Next slide, thanks. So this is our circle of our patient safety evaluation system. This is the flow of information. Under the Patient Safety Act, we have to put data into the system, and that data has to be reported to the PSO. And so that is our first pathway to creating patient safety work product. And typically the data that's input is an incident report or possibly pieces of a medical record or a radiological image, for example. All of that information can be put into the system. A list of patient complaints is another example. And then we get to the blue portions where we analyze and deliberate. We talk about the information. We might have some advanced analytics. There could be investigations, looking at trends, developing scorecards and dashboards. All of this is protected under the second pathway that we're going to talk about, and that's our analysis pathway. We develop corrective action plans and develop feedback, and that can be in the form of new clinical protocols. We have had PSOs in their analysis find that we're missing steps in our checklists and in our clinical protocols, and so we've seen changes in those because of our analysis. And we develop corrective action plans. And then an additional portion of the Patient Safety Act is the idea of assessment, where we take a look and see what's working and what's not working and evaluate our trends and investigate subsequent errors and make changes. And then we repeat the cycle. So there's continuous quality improvement. So let's go to the next slide and let's talk about these different pathways and get an idea of how they work and how information becomes this legal word of patient safety work product, this protected information. So we're going to talk about three pathways. Next, can you hit the next slide? So the bottom piece comes up. Each one of these pathways is independent and mutually exclusive, meaning that we don't have to use all of pathways. We can use one or two pathways, or we can use all three. And so an example, for example, if you have an incident reporting system in your PSES, your Patient Safety Evaluation System, you can report an incident, you can analyze, investigate, conduct an RCA. All of this would be protected under the Federal Act as well as your state peer protections. Both of them would stack on top of each other. And then you can report it all to the PSO, and the PSO can analyze it further, aggregate that information, and provide additional feedback to you. So you can use these sequentially, or the PSO can run a program and come and pull information out of your medical record, for example, and conduct a collaborative with you. So that would just be the PSO pathway. So let's talk about each of these pathways as independent pathways. And again, you can use them independently or you can use them together. So the first pathway we call the reporting pathway. And under the Patient Safety Act, this was our federal response to medical errors, to be able to allow hospitals and health systems to be able to solve their own problems, to identify what our individual problems are, and then be able to create a learning system so that we can develop feedback and best practices and barriers to prevent these problems from happening. The approach is a proactive approach. By sharing information and sharing best practices, we hope to prevent harm that would otherwise occur in every hospital repeatedly across the country. And so that's why we call it our learning system that we want to share across hospitals, across health systems, share with the PSO so that it can get out and help all of the healthcare professionals throughout the healthcare continuum. We follow just culture. So in safety culture, if there is intentional harm, there can be disciplinary action. But in other cases, in the usual course of business, this is non-punitive reporting and it's confidential to the providers. So the information can be discussed among our healthcare professionals, whether they're in your health system or in a health system across the way, as we talked in our last webinar, free from harm, free from litigation, and also free from professional reputation, meaning that it's confidential discussion and it can't end up on the front page of the newspaper, for example. Next slide, please. So again, in our reporting system, it's usually incident reports, and sometimes we report films. It could be a film of an operation as a best practice, excellence, that we love to share excellence as well and learn from excellence. And it can also be nanny cams and other types of quality improvement types of cameras. That's typically all that is reported in the reporting pathway, as well as pieces of a medical record or patient complaints. Most of our work is done under the second pathway under our roadmap, and that is our analysis pathway. And our analysis pathway, our analysis and deliberations pathway, is where we protect all of our analysis, all of our deliberations, all of our communications. Under most peer review statutes, under our state peer review statutes, communications and analysis is limited to committees. Under the Patient Safety Act, under our national peer protections, there is no such limitation. So it's any conversation that you choose to protect and have identified as a patient safety activity becomes protected, and we'll talk more about this. Our analysis pathway 2, our national privilege, is intended to be implemented in the same way as our state privileges are. So when we walk into a quality committee meeting, we typically don't hear someone say, "Oh, you've entered the quality committee meeting. Everything you say is protected under our state peer privilege." And so that's where we're hoping to get to under the Patient Safety Act, where we're going to know that all of the activities that we do for the benefit of our patients is protected under the federal peer protections. At this point, we typically will announce that it is protected under federal law, particularly in areas that we've never been protected before. When I was in private practice, I'd get calls from different hospitals and health systems where I would hear that physicians are uncomfortable in multidisciplinary conferences because they know that there's no protection. Some hospitals would say that that's a committee meeting and that it's educational and retrospective in its approach. And some hospitals have set up their tumor boards and multidisciplinary conferences to take that approach. Under the Patient Safety Act, however, we can protect those. And because of that, your physicians may want to know, oh, you are protected in this particular circumstance under our federal peer protections. So the point, though, is that the protections arise anytime we conduct the patient safety activity, that we don't have to make it too hard and have documentation that our patient safety evaluation system it is present in when our committee meetings or multidisciplinary conferences occur. In fact, the protections arise simply when we do the activity that we have decided is protected under the federal peer privilege. So the act is really easy to implement. And so also importantly, particularly for analysis, the protections can never be taken away. Once the protections attach, once we have decided that our activity is a protected activity under the national peer protections, it can never be waived and it can never be taken away. So next slide. So that's our analysis. And I wanted to show you an example of a real health system analysis pathway. Everything in gray, I know this is a little hard to read, but everything in gray is conducted under their analysis pathway. So they have lots of registries and panel boards, multidisciplinary conferences, lots of committee analysis, all of their OPPE, as well as review committees. Even their board of directors is covered under the Patient Safety Act, and they can have conversations using the peer privilege, the national peer privileged information. So the activities can occur throughout your health system and can include folks from other hospitals and other health systems. I know that we've always been allowing people to come to our peer committees and our M&Ms. and we tell them just don't write anything down. Well, the Patient Safety Act and our national peer privilege enables us to invite folks who can learn from our activities, and they can write things down. And anything that they write down is patient safety work product. So that was one hole in our peer review privilege that was filled by the Act, that the intention is to share information more broadly. And what I'm hearing from health systems is that meetings that they may not have been invited to in the past, particularly our quality folks, they now can attend. For example, it's now becoming commonplace for quality staff to attend M&Ms, and they learn a lot about what's happening in their hospital or their health system that they might not otherwise known through the reporting system, delay in treatment, for example, or other types of events that don't typically get picked up in the reporting pathways. So I just thought that this was a really great analysis of the different aspects that can be protected under the national peer privilege. One thing I'd love to do is take this table and then do some cross-learning within the learning system, and how much of this information is shared with other hospitals and other health systems, and the learnings that can be shared with the PSO as well. So maybe next time we can develop a broader patient safety evaluation system to share. Next slide, please. So our last pathway is our patient safety organization, the Quality Center. Anything that is developed by your PSO with the patient safety activities, so all the information that they collect, analyze, and give back to the hospitals, all the education that they do for everyone, sharing throughout the healthcare continuum. Also, we have PSO to PSO sharing. We are having a lot of safe tables where we might have 2 or 3 PSOs come together and conduct a safe table for the benefit of all healthcare professionals in a learning system. And so anything that is discussed with your PSO, any safe table that we might have, or any information developed and analyzed by the PSO is patient safety work product. Any analysis and aggregation that stays within the PSO is immune. So a PSO can never be subpoenaed for patient safety work product. And then the information that they provide back to a disclosing hospital, for example, the hospital would have to raise the privilege, or the PSO would have to raise the privilege. That information, any feedback given by the PSO is privileged information unless the PSO determines that it's non-identifiable, such as the best practice that they may and you may want to publish or to share with other hospitals and health systems as an example of a best practice or a barrier that we can remove to improve the quality of healthcare delivery. So that's our PSO. So that's our 3 pathways that we use to collect all of our information, how it becomes our protected patient safety work product under the Patient Safety Act. And then next time, we're going to talk about this patient safety evaluation system. And that's always the loudest question I hear is, what the heck is a patient safety evaluation system? So in the 3rd module, we're going to make it very easy for you to understand what a patient safety evaluation system is, and turnkey solutions to make it really easy for the implementation. So next slide, please. I'm going to turn it back to Shelby for comments and see if we have any questions.
Peggy, I did have a question around identifying materials as PSWP. How can you give some examples of best practice of how to label or what to put on a label for your PSWP materials?
Yes, terrific. So we like, as a best practice, to label our information that is privileged using the national peer privilege to say patient safety work product or PSWP confidential. We always like to see the word confidential because so many people don't know what patient safety work product is yet. We'll get there, but we're not there now. Under the rulemaking, if we forget to have something labeled, it doesn't make a difference. It still is patient safety work product. But again, as a best practice, we like folks to be able to know that it is a privileged document. For our conversations, such as our committee meetings that might be covered under the peer privilege, we do like to let people know that we're using the national peer privilege because of the confidentiality protection, but also just to make them understand that they are empowered and protected in a conversation that they may have not been protected prior to this national peer privilege.
Would you recommend then at the beginning of a quality meeting where PSWP will be discussed to just give, a little statement about this is under the PSQIA protections and then a short blurb on what that is in case somebody is new to that terminology? Is that a best practice, or what would you recommend?
Yeah, Shelby, I think that's a good practice to implement. One of the reasons is I think it's fair to let everyone know that it is confidential information and that because our healthcare professionals are covered by this privacy right and that there is a fine for disclosing any of this confidential information, and which empowers our providers to be able to maybe bring to light information that wouldn't otherwise be discussed, that it's fair that they know that these new very powerful protections are implemented during the meeting. So absolutely, until our folks understand that they are protected, over time, we'll be able to remove that disclaimer or that piece of education about the national protections. But I think at this time it's fair to let everyone know when the national protections are being applied. So that is a great question.
Thank you, Peggy. And I'm thinking that would be an awesome time for education. So that would be a win-win. Thank you.
And anyone who is listening on the recording, if you do have questions, please don't hesitate to reach out to the Quality Center as well.
We wanted to just provide you with some links to our Quality Center PSO website. Many of you already have that. If you need a password, please contact me and I can share that with you, as well as Peggy's organization, AQUIP. And as I shared, the Quality Center PSO is a member of AQUIP, and therefore we have access to its website and to use its resources. And I would encourage you to go on that site and explore that. And then, of course, the ARC webpage on PSOs. And I've listed my contact information. Please be aware that during the COVID-19 outbreak, I am working from home primarily. So the best way to reach me directly is to call my cell phone. I am checking my voicemail at the office periodically, but if you need me rapidly, cell phone or email are the best ways to reach me. And just a reminder, our next webinar, as Peggy mentioned, is on the patient safety evaluation system, where we'll be doing a little bit more of a deep dive. This is an area that has some vulnerabilities if policies and procedures and practices are not consistent with PSQIA. So I encourage you to tune into that. And that's April 21st on a Tuesday from 12:15 to 1 p.m. And with that, we will end the webinar. Peggy, James, do you have any additional information you'd like to share today?
You will be receiving an evaluation link. If you could just complete that for us, we do appreciate your feedback. And also, please share any topics or of interest. You may also share those on that link as well.
Definitely.
We do thank you for joining us today.